Good evening, everyone, and welcome to the webinar on EGFR lung updates. It gives me great pleasure to invite our program director, Dr. Nilesh Lokeshwar, medical oncologist and hematologist from Leelavati Hospital, Mumbai, to give the opening remarks. Over to you, sir.
Hi, good evening, and a warm welcome to all of you for today evening's updates on EGFR positive lung cancer. I think the last decade or so has been mainly about finding oncogenic-driven lung cancer and appropriate treatments for that. And we've come a long way from a few months of DFS to now more than a year and a half of DFS and a good overall survival also. But the sad truth is that most of our patients at some point with metastatic disease, in spite of the best of treatment, will succumb to their disease. And the last few years, we've understood so much more about EGFR, the mutations, ways of diagnosing it, monitoring the disease, and some of the newer molecules that are here. So in today's seminar, or we'll try to encapsulate all these different points about EGFR mutated lung cancer. And I'd like to invite, I think the first speaker is Dr. Suparna Rao. Suparna Rao is a medical oncologist at PD Individual Hospital, and she'll be speaking on defining targets in metastatic non-small cell lung cancer with regards to liquid and tissue biopsy.
Can you see my screen?
Yes, ma'am. If you can just put it into presentation mode.
I think it's on presentation mode now. Yeah.
Perfect, ma'am.
So good evening. First of all, thank you to AstraZeneca for this opportunity. So I'll be basically looking into how relevant is liquid and tissue biopsies in clinical practice in metastatic NSCLC settings. So I think this is now almost common knowledge that we have around 40% of our patients who carry some kind of a target in metastatic NSCLC. Most common being EGFR, the other ones being ALK, ROS, MET, HER2, amongst others. There are also emerging biomarkers such as the MET amplification, which is seen, and others being around 30%, and unknown driver mutations being 13%. So from identification of targets, say in the first decade post 2000s, we have found your target molecules against each of these targets, and they've become clinically significant, not only predictive for treatment, but in a way also prognostic. They kind of determine how our patients behave. So once we have a patient of metastatic NLC who's biopsy proven, and we have imaging diagnosis for metastatic disease, so it's almost reflex now to send for molecular testing, either hotspot mutations, but more commonly people now are sending for extensive NGS panels, along with PD-L1 testing, and we have 7 actionable mutations, FDA approved, for which we have targets available. And also, if at all these target mutations are negative, then we, depending upon the PD-L1, the percentages of that by TPS score, we are able to determine whether we want to give immunotherapy alone or a combination of chemo and immuno. So who are the patients and what kind of testing that needs to be done? So for metastatic NSCLC, we know that we have the above mentioned targets along with PD-L1 testing. And this can be done either on a tissue biopsy, which we have always been doing, but more commonly, we also have liquid biopsies on a plasma specimen, which we are able to do for these patients. And in the resectable setting, now we have, targets available against EGFR. We have Osimertinib. Against ALK, we have Alectinib, which is available. And also, if PD-L1 comes positive, then in the neoadjuvant perioperative setting, we also have immunotherapy, which we can give. But however, how to test this is exclusively on tissue specimen, either on the preoperative biopsy or on the surgical resection specimen. Due to low sensitivity, we still don't have liquid biopsy, which is approved. So what are the opportunities? So biomarker testing, like I mentioned, in the resectable setting would give us an idea, whether we should operate them and give them, get targets in the adjuvant setting, or probably if at all immunotherapy is, permissible for that patient, then to do it in a preoperative setting. In the metastatic setting, we'd want to give targets if at all they're biomarker positive. So this could be done either on a tissue biopsy or liquid biopsy, as already mentioned. So there are a lot of studies, I think, is general knowledge for patients who have target mutations. Obviously, their outcomes would be better when we do diagnostic testing and give targets as against those whom we give, just as a blanket chemotherapy. So what are the barriers to biomarker testing in clinical practice? The most important, I think, more commonly is, tissue biopsy, whether the biopsy was done. Invariably, we do end up doing biopsies, but whether the sample collection was properly done, that is processing, whether there was sufficient quantity of tissue, whether the quality of tissue was good. So whether there was enough DNA content, what was the level of necrosis in the specimen, thereby, forming a barrier for adequate retrieval of DNA. Also, not so much so in tertiary settings, but if at all the patients are not accurately staged and if there were improper tissue specimen processing done, that could be a barrier. Biomarker testing is not, it is more or less standardized, I think, everywhere, and there are a lot of labs also at least doing hotspot mutations for quite a few patients free of cost too. And biomarker testing, I think, especially when we send for tests like NGS, so, what is the sensitivity of that? Turnaround time, yes, that could contribute to probably starting treatment, but we invariably start chemotherapy for these patients. If the quantity is insufficient of the specimen, and sometimes, yes, coverage and reimbursement concerns, depending upon which we did, kind of decide on whether the patients would have limited panels or extensive panels. And sometimes reporting also, so lack of timely report to the physician, reports which are difficult to interpret, all those would serve barriers. So the IASLC global survey has said that the main reasons for failure to obtain a molecular diagnosis was insufficient tumor tissue which was provided and inadequate tissue quality. So I think, like I mentioned, the most important barrier would be tissue availability. So around 20% are unable to undergo tissue biopsies, around 3% refuse. Tissue quantity and quality, so around 7 to 20% could not undergo molecular testing due to insufficient tissue or the kind of tumor cell content. And these are 3 studies, of course, of the previous decade, which have mentioned that, probably 1 in 4 or out of 4 out of 10 patients they had test failures. But I think with the most recent panels where the sensitivity has improved, this is not probably so much of a problem, at least in a metastatic NSCLC setting. So what is that we have available, if at all the tissue biopsy, which is the gold standard, is inconclusive or inadequate? Then we have a liquid biopsy wherein we obtain circulating tumor DNA from the plasma sample, and we are able to study various mutations, amplifications, insertions, deletions on this. So essentially, blood contains circulating free DNA, both released from healthy and tumor tissue. So tumor tissue DNA is what we study. So I think almost always we try and send the NGS for these patients with, higher sensitivity, and that's what is recommended. For patients, wherein probably it's a little difficult to do due to whichever reason, then we tend to send hotspot mutations, which are essentially detected by RT-PCR or sometimes IHC, depending upon the mutation. So what are the procedural methods? Like I mentioned, the metastatic setting, through whatever biopsy, and sometimes probably cytology specimens, we try and, get molecular testing done on the tissue specimen. And if at all, sometimes probably as a complementary or alternate method, we do a liquid biopsy. In the early stage setting, like I mentioned, liquid biopsy has not been validated and is not recommended as yet. So this was basically a study which looked into positive concordance between plasma and tissue specimens depending upon the stage, and only with higher stages, probably when you had adequate material DNA content to run these analysis, was where you actually managed to get mutations both on the tissue and plasma sample. With the very early stage, the sensitivity was very, very low. So it's really not possible for us to probably achieve the kind of results that we want in an early stage setting. And for tumor sizes which were less than 3 centimeter, obviously the concordance was much lesser compared to patients who had a higher tumor size. And in the metastatic setting also, the sensitivity of a liquid biopsy is only 70 to 80%. So there could be false negative rates of 10 to 20%. So if we have run only a liquid biopsy for whichever reason, then if it comes, we're not able to identify a mutation, it still probably, is important for us to try and achieve a tissue sample. So this was basically studies which looked into concordance between the circulating free DNA and tissue to identify mutations. Like we expected, the sensitivity was around 70 to 80%, and the concordance for both, for all these more common genes which we tend to target and treat, was 98% between the tissue and the plasma sample. The one great thing with liquid biopsies is that the turnaround time is very, very quick, sometimes 1/4 or probably definitely half compared to tissue NGS, even for extensive panels, such as Garden 360. I think we have turnaround times of just around 10 to 14 days now, which is great. So this is again a study which looked into, giving us confidence that once a target is identified, irrespective of whether it's liquid or tissue based, the PFS was similar, which meant that the specificity is very good for both these and almost equivalent for both these, testing methods. So this again was just a slide showing that 85% targets were, of patients who received liquid biopsy did achieve some kind of a response. So this is, I think, kind of corroborating to what we would anyway see with trials. So how to improve sensitivity? Tissue first alone identified 60 patients, liquid alone around 77. But when we combined both, then we almost improved the identification by almost around 50%. So it would actually make sense, if possible, to send both the tests simultaneously. And where would liquid biopsy kind of help or overcome the challenges that we face with tissue biopsies? That would be, if at all it's difficult to undergo a biopsy due to patient's suboptimal clinical condition, if it's an difficult site to target to obtain a tissue biopsy. If at all there's a scarce tumor tissue, so where you have a quantity and thereby also probably a quality issue with the tissue biopsy. Also in case where we have a histopathological diagnosis, but again, not adequate content. So we could probably spare the patient from undergoing additional invasive procedure, especially if it has, risks involved. And more than anything else, it helps us support, and get results much quicker compared to tissue biopsy. So if sending both of them, the liquid biopsy having, pretty good sensitivity would help pick up mutations and probably start treatment earlier. So this basically is similar to what I've already said. And one important thing with liquid biopsy is able to overcome the tissue heterogeneity, which could be probably missed with tissue-based testing. We've all had patients wherein tissue has not picked up results, but there has been identification of targets on liquid biopsy. And like I mentioned, the most important thing is the turnaround time is much quicker. This again, just comparing, how, what are the different things with liquid versus tissue biopsy. So I think the one thing with liquid biopsy or doing them both concurrently is that the cost of testing would be much higher, but detection of mutations would be much, much higher. The sensitivity, like we saw, was almost 50% higher as against just doing tissue biopsy. And the turnaround time is also much quicker when you do a liquid biopsy as against an NGS panel for a tissue biopsy. So what is recommended in various guidelines is liquid biopsy could be done as a complementary test or as an alternate test when it's not possible to get results from a tissue biopsy. But when we've done liquid biopsy alone, and if it's non-informative, then it's important to do a reflex, make a reflex attempt to get tissue and send for analysis again, because the sensitivity is only around 80%. So these are diagnostic algorithms. So what are the three kind of approaches that we can use to kind of pick up mutations when we use a liquid biopsy, or how do we use liquid biopsy tests? One would involve doing liquid biopsies alone when tissue sample is unavailable or it's not possible to get. That would be a plasma first approach. But like I mentioned, if at all we don't identify a target, then it's important to try and obtain a tissue biopsy. For patients where it's possible to get a tissue sample, then you could do it sequentially, wherein you're not able to, run an analysis because of incomplete tumor genotyping and you want to do a liquid biopsy to get adequate information. Otherwise, you do a complementary approach where you kind of send both when you're not certain about the adequacy for genotyping. These are two guidelines that we commonly use, ESMO and NCCN. So ESMO Clinical Practice Guidelines has looked into using liquid biopsies also. It has come more recently in the metastatic setting in 2022. It's recommended in treatment-naive patients when there's an expected delay to obtaining tumor tissue for genotyping, when the invasive procedures could be too risky or they're contraindicated, or bone is the only accessible biopsy site, wherein again, adequate retrieval of DNA content might be a problem. Again, it could be considered as a complementary or alternate to tissue biopsy for NGS testing. And it's acceptable if at all we want to look for identification of mechanisms of resistance to the target against which we have given TKI. So caution should be used. So what are the limitations with plasma testing is it could miss epithelial mesenchymal transformations, that is histological transformations. It may have inadequate sensitivity for MET true gain, basically for copy number gain, especially in the setting of patients where we've given osimertinib upfront, and they're suboptimal for detecting amplifications and fusions. So in these particular settings, probably it would make sense to do a repeat testing. This is again a lot of information just from NCCN, wherein they have said that again the false negative rates are 30%. So it's important to do it alongside a tissue biopsy. There could be clonal hematopoiesis of indeterminate potential mutations which are picked up. These variants called as CHIP, for example, IDH1 in an NSCLC, where we don't really know what it would, how it would make a difference prognostically. So these are things which we need more information on. So, however, plasma DNA testing is recommended in where a patient is not medically fit for an invasive tissue sampling, or where there's uncertainty about the sufficiency of the sample. So it's so how where we would mostly use it is in a where we have progression on a first line first generation TKI, and where patients have a TKI, could develop T790M mutation. Let her finish the call with us. So circulating tumor DNA should not be used, like they mentioned finally, in principles of testing in lieu of a histological diagnosis. It's not routinely recommended in a resectable setting, that is stage 1 to 3. And like I've already mentioned, sensitivity to an issue, chip clones could be a problem. And we need to exactly know where we would want to use liquid biopsy testing. So I think that's what I'd like to end with. So we have both solid and that is tissue biopsies and liquid biopsies, and there are not protocols, but I think we more or less know the settings where we have to use it upfront in the treatment naive setting and the relapse setting or a progressive setting.
Yeah, thank you, Dr. Suparna Rao. That is an excellent talk about liquid biopsy and its role in, driver mutation lung cancer. I had a question for you. In how many patients do you upfront do both a tissue biopsy as well as a ctDNA? And do you think there's any merit in doing it that way?
So I have seen cases where we have not picked up much on the tissue, but we have found mutations like EGFR ALK on the liquid biopsy. Most of my patients still can't afford both, so I tend to send tissue biopsies, first, and then liquid biopsies probably, at least when we're looking for a T790M mutation, probably in a relapse setting. But I've had cases, like I mentioned last week also in a meeting, where I did hotspot mutations and that turned out negative. But when we ran an NGS panel on liquid biopsy, we did pick up targetable mutations, and the patient had progressed on PEM-carbo and docetaxel. But we started with a 1% VAF also. We started osimertinib and she's on CR. So I do feel there's a lot more merit now in probably doing an NGS definitely on the tissue biopsy upfront, because the sensitivity is much higher. But if we have done hotspot mutations, then definitely to try to send for, not necessarily a Garden 360 or a Foundation 1, but definitely, even limited panels of 72 genes wherein we have picked up. And this I heard from many of my colleagues. So I feel after those kind of cases, there's a lot of merit in, if not sending both together, at least doing an extensive NGS panel on a tissue biopsy.
Yeah, I agree. I think I have also had similar experience. In fact, two patients, both of whom had initially undergone hotspot testing and were negative, and then they got the chemotherapy and multiple lines. And at a later date, when the liquid biopsy was more accessible, in fact, both of these patients were positive for exon 19, and now have been on a EGFR inhibitor for a very long time.
So I think especially females, young patients, and from whatever I noted, that colleagues who had younger patients, females are wherein I think this got missed. So if at all, definitely a non-smoker, younger female, younger males also, then definitely I think we should kind of emphasize on doing an NGS testing. Then spending 1 year on chemo and then realize this patient was EGFR mutated.
So having said that, I think in a patient where, say, the initial biopsy does not show a targetable lesion, I still try to encourage them to do a liquid biopsy because of these couple of incidences that have completely changed their treatment. I think a biggest challenge is the cost of the testing. While you have a lot more affordable tests, some of the standardized ones are extremely expensive and out of the reach for a lot of the patients. So anyway, thank you so much. That was an
Thank
excellent
you.
talk.
Thank you.
Yeah. For the next talk, I'd like to invite Dr. Tejinder Singh. Dr. Tejinder Singh is a medical oncologist at Apollo Hospital, and he'll be speaking on the real-world evidence of osimertinib in first-line therapy non-small cell lung cancer. Welcome, Tejinder.
Yeah, thank you, Nilesh. So Suparna had given a very nice talk on looking at into the how we use it. I think one area where liquid might be slightly more useful is when tumor heterogeneity we are not having an issue. Anyway, so I'll discuss about the real world evidence of osimertinib as a first line therapy in lung cancer. So this is a famous FLORA trial, which we know is a double blind study. And it looked into the usage of osimertinib, and they had stratified the mutation status based on the exon 19 and L858. And the key inclusion point were mainly locally advanced or metastatic NSCLC and more than 18 years with exon 19 or L858. So this trial basically laid the foundation for a usage of osimertinib in this particular group of patients. And you can see the baseline characteristic quite well matched here. Good number of patients were Asians, CNS metastasis at study entry, nearly 20 patients who were there, because initially osimertinib got approval for 790 and those patients with CNS metastasis. And they had also randomized based on the exon 19 and L858. That was one of the stratification factor. Coming to the primary endpoint, which was a PFS, you can see a gross difference of nearly, point hazard ratio was 0.46. Median PFS of around 18 months as compared to 10, with a delta of around approximately 9 months difference. And you can see a difference quite early in the course of the treatment. Almost every type of stratification pattern basically showed response to osimertinib. This is a final OS data. Curved basically separated quite early. The median OS was around nearly 38.6 months as compared to 31.8 months in the comparator arm. And this is a CNS analysis, a very important point, because ultimately most of the patients, when they relapse in the brain, and you can see a difference quite early also, hazard ratio of 0.48. So a clinically meaningful improvement in CNS PFS over the other TKIs in the first line treatment with CNS meds from the EGFR mutant patient. And there was a nearly 52% reduction in the risk of CNS progression. Now, this is a cumulative incidence of CNS progression at 6 months and 12 months. And the probability of experiencing CNS meds in the absence of non-CNS progression was very low in the osimertinib arm as compared to the comparator arm. And this is a safety analysis, quite a safe drug, has been in the practice for the many years, and all of us are well versed with the Tagrisso, and we know the safety profile are quite good, quite similar to other comparator arm, despite a longer duration of exposure. We have patients now who have been taken for nearly 4-5 years also. So the conclusion of the FLORA was that osimertinib resulted in a significant improvement in PFS, hazard ratio of 0.46, also increased duration of response, 17 months as compared to 8.5 months. And it had demonstrated a statistically significant and clinically meaningful improvement in OS versus the EGFR TKI. And the median OS was extended by nearly 6.8 months. And it showed a nominally statistically significant and clinical improvement in the CNS PFS versus EGFR comparator. And the safety profile was quite similar despite prolonged exposure. So what I think the question does come over there is that, when we talk about looking at FLORA versus real world, the OS and the PFS which was seen in the FLORA, will it be replicated in the real world? And the group was basically more of 60, 64 years. What about people who are very elderly, 70, 80 years? And talking about the improvement in the CNS PFS, whether in the real world also this is showing improvement or not. So these questions basically, that's the reason why real world studies are there, where the data is collected from patients treated in the clinical practice who represent the real world population, including patient with specific population. So, there is a difference between slightly in the RCT and the real world. In the RCT, you have wide unequivocal acceptance. There's a homogeneous patient controlled care is there. High interval internal validity is there, and generally used to look into the efficacy and the safety. And whereas the real world data, basically even though the acceptance is low, but talking about the representative pattern of patient population is much better. Application wise, wide variety of healthcare decisions are taken with the real world evidence, and validity wise, naturally the RCTs are slightly better over there. Now, how do we address this question about real world evidence? I think now Osimertinib has been there in the market for a good number of years. We have now so many well-known real-world data. One of the well-known data is the FLOWER study and also the OCFACT study. But there are other studies also which are there from every part of the world. So today we are going to discuss two studies. One is the FLOWER study and the OCFACT. But the other studies like Spanish HOT 2002 studies and Mykonos are also there. So FLOWER study was basically is a real world prospective observation study, mainly looking into refer to 9 Italian oncology study, and OCFACT is a study from Japanese area. And then there's a study called HOT 2002 also, which looked into especially people who are more than 75 years also. Now, PFS when we talk about PFS in the real world, I think there are certain definition important. We look into the time to treatment discontinuation, which is basically a term starting from the date of starting the medication to the date of treatment discontinuation, a very important endpoint to evaluate patient outcome in the real world scenario. Time to treatment failure, which is also TTF, it's from the first dose to the date of last administration, and the time to next treatment of the death or the death. So TTND, NTD also. So that is but PFS has been maintained in the real world study. So today we'll be discussing too much on the TTD, which is time to treatment discontinuation, time to treatment failure, and time to next treatment. And most of the studies have looked into it. Now, talking about the PFS, when we talk about the FLORA and the other studies like FLOWER, OCFACT, Spanish, and Mykonos, which was basically using the which had the USA and Germany group, and the people who are more than 75, the HOT 2000 study, you can see a PFS almost similar in all the real world studies. So PFS had been maintained in the real world study approximately around 18 to 20 months, even though in the Spanish it was much more than the as compared to the FLORA data. Now, FLOWER was the first real world data. It was a inter-regional prospective study. It's a Italian group, 9 centers were part of it. They had taken patients from June 2018 to June 2020. And the group they involved was first-line metastatic advanced, and 67, 68 was a median age group, and they had nearly predominantly adenocarcinoma. And also patients who are brain mets were nearly 30%. And you can see here the partial response outcome-wise, nearly 73% had a partial response, stable disease 23. Progression was only seen in the 4%. And TTD was treatment discontinuation was there in nearly 25 months, nearly more than 2 months. And also median TTD in patient with or without symptom was around 18 months. So PFS was around, as compared, you can see the PFS of the standard arm. And this study also showed that the most common side effect was diarrhea and rashes. Paronychia was also there, but there was no difference in the cervical outcome according to age, comorbidity, and the type of mutation. So in the real world, this was the first study which confirmed about safety and effectiveness in the real world. Talking about the OCFAC study, which was basically a Japanese-based real-world study, and you can hear the median age group was around 71 years, and brain mets at around 30 months, 30%, so similar to what we saw. And the duration of response was quite good. 94% had good duration of response. Median PFS was around 20.5, and the overall response rate was also 76. So here the PFS after the first osimertinib real world treatment in the real world practice was favorable. Another important point is the median time from the start of treatment to the onset of adverse event. It was nearly 56 days, almost like 2 months. And they do had some patients who had pneumonitis, but reasons for discontinuation varied a lot on many things. So Mykonos was a study which basically had data from both the US and Germany, predominantly from the US and Germany. And this study also had similar age group. Median age was around 70 years. And you can see here the real world time to next treatment or death and treatment real world time to treatment discontinuation was around 17 months. And a median at a median follow-up of 9.6 months, the real world time to next treatment of death was around 18 months. So the interim analysis also showed here the effectiveness in the real world data. This is looking at the PFS. So the final data from this interim analysis is that the PFS is approximately 16.2 months. Time to treatment discontinuation is 19 months. And time to next treatment of death is around 14 months. And this is based on the first data analysis over there. Now, Spanish first line real world data. This is also was a multi-center Spanish study. And so the data was collected and analyzed. They primarily looked into 2-point PFS in the OS. And with a median follow-up of around 18.7 months, the OS had not reached. So you can see here the PFS of around 25%, 25 to 26 months. So this study also looked into the efficacy, and they found a good efficacy of osimertinib in a real world scenario. So important question was that will the benefit be seen in the elderly? Like I said, it is a 2002 data. This was basically a study which primarily looked at the old people more than 70. Here you can see here a Japanese study. Here the median age is 80 years and median PFS is 19.4 months, and the OS was not reached. So basically, even in population who are 75 and above, the real world data as per the study is quite good. So question does come into about the meta-analysis in older patient. I think the overall conclusion of all the study also on the FLORA is that the study concluded that the osimertinib achieved a higher PFS than all other EGFR TKIs, and it's a preferred EGFR TKI for treatment of older males with advanced EGFR mutated lung cancer. What about the benefit with CNS mets? I think FLORA has been very clear about it, and FLORA China was also put up over here. You can see here out of 136 patients randomized, 24% in the osimertinib and 32 in the comparator had baseline CNS mets, and the incidence of CNS progression was lower when patients are given osimertinib than patient given comparator, 3% as compared to 20, and the PFS benefit in those patients who had CNS mets were consistent. So you can see here the CNS met at baseline without CNS met hazard ratio is almost same over there. So osimertinib and as a first line head-to-head comparison, basically you can see here erlotinib versus gefitinib, the patients afatinib versus gefitinib, decometinib versus gefitinib, and osimertinib versus erlotinib. I think almost all of us know about different studies because Archer looked into decometinib versus gefitinib. Here they had excluded CNS met. Afatinib versus gefitinib also they had specifically left all this bad prognostic feature patient like CNS met. So most of the studies had excluded the brain mets except for the people, except in the flora which they had included. So overall response rate in lung cancer, CNS met treated with the first line is approximately 70%. Duration of responses in this particular group is 93%. Median PFS, when you look at it, is around approximately 13 months. So what does the NCCN says? I think we know all these things right now because in those patients where osimertinib has come as a category 1 and as a preferred, other recommended are there where nowadays you have pemetrexed with osimertinib also, but apart from the afatinib, gefitinib, everything has part of it as a recommended one. So to summarize, I think real world data help in evaluating the efficacy of osimertinib patient who are usually excluded in the RCTs, and osimertinib has demonstrated benefit in the real world constant with the results seen in the flora, and current real world studies show clinically meaningful efficacy of osimertinib, especially among patients of certain age group like more than 75 years, presence of basically brain mets, ethnicity, specific mutation types, and more emerging real-world evidence studies are anticipated covering various population type, which in turn would get into deeper insight about osimertinib potency in the larger scale. Thank you. Thank you, everyone.
Thank you, Tejinder. So I think your talk on the real world data actually validates our experience as well as the trial data regarding the use of osimertinib in the first line setting for EGFR mutant lung cancer. So while we acknowledge and accept that it is one of the best treatment options there, in practice, not all patients can take the drug. So what is your approach in these patients? Do you prefer a sequence? And if you do that, what is your choice of drug and how do you choose that?
So I think the rates have slightly come down. They have further decreased the rates based on the patient assistance. But I think one area where most of the patients who are not able to take osimertinib, basically, I normally put them on chemotherapy with gefitinib. Another subset is giving only afatinib also because the rates are almost same for afatinib and gefitinib. But the real issue comes with the CNS meds. You know, there's somewhere down the line you have to convince the patients. But like you said very clearly, many of the patients they cannot afford, then you have to go ahead with the radiation, nothing else. But given a sequencing, I don't believe in it right now. But if you cannot afford osimertinib now, I don't think you'll be able to afford later on.
Correct. Thanks, Tejinder.
Yeah.
So we'll go to the next talk. And for this talk on uncommon mutations, we have Dr. Adwaita Gore, who's medical oncologist at Nanavati Max Hospital. Dr. Gore will be speaking on managing less common driver mutations. Over to you, Dr. Gore.
Thanks, Nilesh, for organizing this wonderful meeting. I will share it from my end because I think that this is something which is a very practically. I hope you can see my screen.
Yes, you can see.
How is it full screen?
Yes,
Yeah.
it's full screen.
So I'll be speaking about managing these lesser common driver mutations. Now, just a sec. So these lesser common driver mutations are essentially being more and more identified by all of us now, because as we heard Suparna speak in her talk and also Tejinder speak about the various EGFR inhibitors and the osimertinib story, NSCLC in terms of diagnosis has also evolved from histology to a molecular subtype kind of classification. And these diagnostics have actually led to the transformation of the treatment to a mutation-specific treatment regime also. So I think this is the most important part of deciding therapy for patients today, that on day one, when I send an NGS, I would like to have all the information about the disease, and that will help me select a drug which is based on that particular mutation, not just EGFR or ALK or ROS, but even more detailed specific mutations based on that. We've all seen the L858R mutation story, initially gefitinib, then afatinib coming in saying that it is better, then dacomatinib was better for it. And now we are practically using osimertinib for all patients, all comers with any EGFR positivity, because it is shown that for the activating mutations in EGFR, osimertinib is the drug of choice, more or less cemented as a first-line therapy. The testing methodology also for targetable mutations, we need to understand that for EGFR, a PCR-based technique or a NGS-based technique is what is approved. For ALK, IHC is necessary, but if IHC is positive, it needs to be confirmed with another test like a FISH. Same goes for ROS1. And for PDL1 is the IHC testing, which is approved to be as an ideal methodology for the targetable mutation. So there are multiple different complex mutations which we now come across, especially because our ordering of NGS has also gone up. So we do see lung cancers with TP53 mutation. We do see them with HER2 fusion proteins. We see them with PIK3 kinase mutations. And at times we are foxed in terms of what is to be done. So one caveat that I would say is that we should all wait for molecular testing results before starting therapy, and we should not initiate immunotherapy just on basis of the PDL1 test result, which comes to us within just 2 days of getting the biopsy, because most of the centers now have in-house either the Ventana platform, that's the most commoner available one across various institutes, so that within 2 days we do get a SP263 assay readily at our centers. So the testing demands for pathologists have also increased. These are all the different rearrangements that we look at in ALK, where there are therapeutic drugs. We look at alectinib, brigatinib, and now lorlatinib, especially with the Crown 5-year data, which has come out last year. The ROS1 rearrangements, we look at BRAF V600E mutations, the NTRK, MET exon 14 skipping mutations, and RET rearrangement. These are the more common ones. HER2 mutations, yes, and now the new kid on the block is the KRAS G12C mutations, which has therapeutic targets. And there are certain genetic aberrations which modulate these targeted therapy or immunotherapies, especially when we see co-mutations like the STK11 or the PIK3 kinase, the RB1, then we know that these patients may not really respond very well to immunotherapy also. The TMB status, it is different for tissue, different for blood. Generally for tissue, TMB high is anything about 10 mutation per megabase, but if you send it for blood, you need to confirm it with the lab. Most of the labs have it as 20, that's the cutoff, and that is what one would look at. So this is from the ASCO guideline that currently what we look at in terms of EGFR. Tejinder just spoke beautifully about osimertinib, which has a level 1 evidence. This is for exon 19 and L858R as first-line therapy. Most of these patients, if they receive osimertinib, they generally don't develop a T790 mutation. They would need to be on a platinum doublet with immunotherapy and bevacizumab, the ABCP regimen as the second line. However, for patients who received a second generation TKI and have gone on to develop the T790 mutation in following progression, osimertinib becomes the drug of choice in second line. When we are looking at EGFR alterations, when we look at mutations which are other than exon 20 insertion alteration or the T790 mutation, there are certain activating mutations, namely the G719X, the L861Q, and the S768I. And these mutations are very important to be identified because level 1 evidence here is with afatinib. Osimertinib is a weak recommendation in these group of patients. However, if patients can't go in for afatinib, a standard chemotherapy regimen would be the treatment of choice. With patients in exon 20 mutations that we are dealing with, yes, chemotherapy with amivantamab or amivantamab with one of the newer third or fourth generation anti-EGFR therapies like lazertinib can be used. And patients who've received prior chemotherapy, especially in exon 20 insertions, amivantamab can also be used in second line. Now, coming to a horde of other investigations, I know this is a busy slide, but I have just kept about 6 slides in this entire presentation. So for patients with ALK rearrangement, we again have a very strong evidence for all of these. We have it for alectinib, brigatinib, lorlatinib, ceritinib, as well as crizotinib in the first line. And I think a optimum selection of patients, especially those with CNS disease or patients who are having neuropsychiatric problems. Lorlatinib should be avoided. Alectinib is also an equally effective drug in patients with CNS disease, although the CROWN data, which has clearly shown that lorlatinib versus crizotinib, it's a huge difference in the PFS curves that we see at this point of time at 60 months of follow-up. What drug is used in the first line, we will need to move on to a second line therapy, which is also equally effective. And lorlatinib, alectinib, brigatinib have been approved in second line and also beyond that. In terms of ROS1 rearrangement, crizo and entrectinib, these are the ones. Entrectinib or crizo is not available, then we can use ceritinib, or there is recent data on using lorlatinib also in these patients. This data was presented in the ASCO in the ESMO 2024 now. Patients who received prior crizotinib, entrectinib, we can use lorlatinib in them or a platinum-based doublet. Now, BRAF V600E mutation is very, very rare. Less than 2% of patients may have this. Dabrafenib, trametinib is a readily available combination as of today. Encorafenib, binimetinib is actually not available currently, and procuring it requires a task. Now, MET exon 14 skipping mutations are also seen in about 2 to 3% of patients. Capmatinib, tepotinib, both are readily available. However, we also need to understand that if there are co-mutations, we need to target them too. The RET rearrangements, selpercatinib had a support program, but currently we do not have any program for it as of now, and procuring the drug is a bit difficult and out beyond reach of most of the patients. In terms of NTRK rearrangements, larotrectinib, entrectinib can be still availed on compassionate basis. So all of these drugs do really have a very strong level of recommendation to be used in this scenario. Now, the new kid on the block was the G12C KRAS mutations, where sotorasib and adagrasib are used. Generally, most of these patients are treated with chemotherapy in first line, and then second line, these drugs are used. In terms of HER2 alterations, TDXD has a very good recommendation to be used in this scenario. So the takeaways for my talk is that even though there have been several tangible oncogenic drivers which have been identified, these therapies do benefit practically only half of the patients of NSCLC that we treat. Most patients do not have a targetable mutation, or we do not know what the mutation is because of our limitations. There are potentially targetable mutations which are continuing to grow. The newer ones which are added are NRG1 and the CLIP-LTK fusions. There are certain other mutations with the DNA damage repair pathway, the STK11, which can also tell us about the resistance pathways for immunotherapy. Obviously, further research to develop agents towards these targets is already ongoing, and why patients do progress on the existing targeted therapies and what are the mechanisms of resistance to available therapies is really going to be the future of trying to understand how to treat these mutation-driven tumors. I thank you, Nilesh, for again having all of us here for this meeting. Thank you very much.
Thanks, Advait, for this glimpse on the management of uncommon mutations. So, whenever we do an NGS, more than the patient, I think we are so hopeful that we pick up something. And I've been always looking for an NTRK in lung, but I have not been successful. Any experience regarding?
Yeah, so not with NTRK actually, but we've had patients whom we've had dual mutations. So patients having EGFR and ALK mutation, patient having an EGFR with a TP53, and there have been multiple papers which have looked at looking at these subsets of co-mutated situations where patients may have actually inherent resistance to the TKIs that we are offering. So, for example, a TP53 along with an EGFR, patient's survival with osimertinib alone is only about 9 months of PFS as compared to beyond 2 years as what we saw with the FLORA. So possibly giving osimertinib alone may not be enough in these patients. We may need to combine it with chemotherapy. More data will come in from the FLORA 2 study. or look at combinations like a VEGF along with an EGFR, as we have data for ramucirumab with erlotinib or bev with erlotinib. These may be one of the options to look at targeting the TP53 also along with the EGFR. So that is something which we need to keep in mind when we are looking at the NGS report. And I believe that we all should look at and push labs so as to they do it in greater depth and not just 100x or something like that. Because then that really picks up a lot of noise and we really don't know what mutations that they are reporting to us are really meaningful or not. Not many labs also report the VAF, so it's actually difficult to interpret. And at times, I find myself asking patients to get second opinions on the NGS or sending the test repeat to some other lab because the lab where we are not getting the correct answers what we are looking at.
So, Advait, the FLORA2 data actually included patients with exon 19 and L858R. Do you think that combination of osimertinib with chemotherapy, PEM-CARBO, is also an acceptable option in the uncommon EGFR mutation? I'm not talking about insertion 20, but the other uncommon mutations.
Yeah, so I think what we even saw from the TMH group paper with Vijay and Vanitha, that Jeftinib with PEM, they have in fact published their long-term
Yeah.
results this year with the 5-year follow-up, and that shows that the survival is really good. It adds on to the toxicity. Probably osimertinib or jeftinib, when you compare, osimertinib is lesser toxic as compared to jeftinib. So if there's a patient who has complex mutations, I would possibly offer chemo with osimertinib to that patient today.
Yeah, thank you so much, Advait. Thanks for your thought. So we'll go to the next part of the talk, and that will be a panel discussion, which I'll be moderating. And we're basically speaking about, is it going to be only TKI or TKI plus something in patients who got advanced metastatic EGFR mutant non-small cell lung cancer? And for this, I'd like to invite my panelists, Dr. Shruti Arora, medical oncologist in Nanati Max Hospital, Dr. Darshana Rane, medical oncologist from HCG Hospital, Borivali, Dr. Atul Narayankar, medical oncologist from Wockhardt Hospital, Dr. M.R. Kaushik, medical oncologist and hematologist from INS Ashwini Hospital, and Dr. Preetam Kataria, medical oncologist from Reliance Hospital. So, are all my panelists here?
Yes, sir.
Yes, sir.
Okay. So, would you be putting my slides to the Kavina creation team?
Yes, sir. So we've shared it. You can say next whenever you move, or whenever you want us to move to the next slide.
Okay. We'll go to the next slide. So, I mean, this is a slide that's all common to all of us. We are well aware about the benefits of the different generation of TKIs over the last 15 years, right from the first generation TKIs like Jeftinib and erlotinib, which had a median PFS of around a year, to the second generation TKIs, which really didn't live up to the promise that we had expected, and they gave us about 12 to 14 months of PFS benefit. And then finally, you had the third generation TKI, Osimertinib and Adwaita and Tejinder have both shown us all the data from these trials. But even with Osimertinib, the median PFS is somewhere around 19 months. Next slide, please. So obviously, there is a lot lacking in this group of patients. If you look at the slide or the graph on your left, the 3 years, the probability of overall survival is about 54% with osimertinib and about 44% with the earlier generation TKIs. And the number of patients who continue to receive the first-line therapy keep dropping off year after year. In fact, at about 3 years, there's just about 9% of patients who are on the first generation TKI, and even in the osimertinib group, just about 28% or just about one third. So a lot of patients progress and either die from the disease or move to the next line of treatment, even when they are on osimertinib. So there is a real unmet need as to how to improve the outcomes in patients who got an EGFR mutant lung cancer. Next slide. So there have been a lot of combinations with the earlier TKIs. So you had several studies which have used gefitinib and in combination with chemotherapy backbone like pemetrexed and carboplatin, including our own study from Tata Memorial Hospital, which has shown a significant improvement as compared to single agent gefitinib alone with regards to DFS as well as OS. Next slide, please. So my question to all my panelists is, and we can answer it one by one, is what is your experience of using a combination of single agent of the first generation TKI along with a chemotherapy backbone? Please share your experiences about this. We can start with Dr. Shruti.
Sir, we have combined gefitinib with pemi carbo, and I think it is good for our Indian patients. Tolerance is also good. So overall, I've seen toxicity. There's no new, or toxicity that I have to see when I combine TKI with pemi carbo, but I've only combined the first generation.
So any concerns with myelosuppression, increased rash, diarrhea, or you think it's in a young fit patient? Is it okay? Are you going to give it to all patients?
So young fit patients do very well, and in elderly we would not really go for the combination, the frail patients. So it's generally the young fit patients that we prefer this.
Okay, Dr. Darshana? Is Dr. Darshana there? Dr. Atul, can you take that, please?
Yes, sir. So, yes, I am using combination, particularly in patients who are below the age of 65, or in few patients wherein they are not able to take osimertinib for whatever reason. I prefer using combination, and experience has been pretty good. Only few patients I had to manage the dosing or increase the interval of chemo in between. One patient I had to actually discontinue pemetrexed during the maintenance period, but I have seen like one patient on going up to 2 years also with the combination. So
do you give it for 4 cycles or do you give it up to 6? How do you do that?
Four cycles combination, then maintenance with pemetrexed, sir.
Okay. And what about your experience, Dr. Kaushik? I think at your center, cost is not really a big problem, as most of the patients would be, beneficiaries of the government service.
Definitely, cost is not, but again, osimertinib is not easily available for everyone. So what usually happens in our setting is, one, we don't have an in-house NGS. So we do start everyone on chemotherapy, and by 2 to 3 weeks, we get NGS report and they are eligible for EGFR TK. We do add them along with the ongoing therapy. So that's how majority has this combination of chemo plus TK combination, and we continue for around 4 to 6 cycles and then keep on maintenance PEM plus TKIs.
Okay. So even at your center, you do have a challenge in getting osimertinib for all your patients. Am I right?
Majorly.
Okay. Dr. Darshana, you joined us. Do you use the first generation TKI with chemotherapy as compared to osimertinib, and what's your experience?
So yes, first generation TKI we are using, but very few people are affording osimertinib in that case. So it is generally the gefitinib which is used along with the chemotherapy backbone is what we are currently following. Though the osimertinib has now come in reduced cost, the cost is still not that affordable to the common population. So we are not really using it upfront.
Okay. Preetham, any particular choice of patient who you'd consider for the combination versus, say, single agent first generation TKI? Okay, I think Preetham is lost out. So the question is never about. Preetham, are you there?
Yeah, Preetham. Yes, sir. Yes, sir. So I think, for majority of the patients, based on what is the fitness status and the age of the patient, we can combine gefitinib with chemotherapy. With the FLORA2 data in, I think there's a, those patients who can afford osimertinib can be combined with chemotherapy for certain subset of patients, especially those with CNS metastasis, where the benefit is more, or stage 3 or stage 4 patients. Yeah, the concern remains about the some amount of side effect profile. So the patient selection is very important combining the TKI with chemotherapy.
Thanks, Preetham. I think the main concern with regards to using a first generation TKI along with chemotherapy is the higher incidence of CNS progression. And that's because, these drugs don't have CNS penetration. Can we go to the next slide, please? So therefore, there have been several attempts to consider newer combination therapy, and that includes a third generation TKI, osimertinib with chemotherapy, as well as other monoclonal antibodies with the third generation TKI drugs. We'll go to the next slide. So the first study that has used this combination is the FLORA-2, which used a combination of osimertinib plus pemetrexed and carboplatin or cisplatin for 4 cycles followed by maintenance, as opposed to osimertinib alone, which was in the control arm. And this basically included patients with both L858R as well as exon 19 deletions, and they were in first-line setting. The primary endpoint was PFS. The secondary endpoint was OS and ORR. We go to the next slide, please. And similarly, the other trial is the Mariposa trial. Again, patients with locally advanced or metastatic non-small cell lung cancer with either of the 2 common mutations were further randomized to 3 arms: amivantamab with lazertinib versus osimertinib. And there was a third arm that was only lazertinib, which was not considered in the primary analysis. And that was mainly to assess what the contribution of the individual drugs are in this whole combination. Amivantamab is a new drug. Many of us have heard about it. I have at least not used it much. It was given in 2 different doses. If less than 80 kgs, it was 1050 milligram. If more than 80 kg, it was 1400 milligrams weekly for the first 4 weeks, and then 2 weekly till progression. Lazertinib, which is again a third generation TKI, was given at the dose of 240 milligrams daily versus the study arm, the control arm, that is osimertinib, at the standard dose of 80 milligrams per kg. And here again, the primary endpoint was the PFS by the central review, and the secondary endpoints were the OS, the ORR, and the duration of response. Next slide, please. So the FLORA-2 data is well known, and it's been published last year. So there is a significant improvement in the PFS with the combination arm of osimertinib with chemotherapy, and the increase is it's a statistically significant improved HR of about 0.62. The combination showed a median PFS of 25 months as opposed to the monotherapy, which is 16.7 months. And similarly, in the central review also, there was an improvement with a hazard ratio of 0.62. Next slide, please. Then again, you have the Mariposa data, which has shown an improvement in the PFS, an improvement from 16.6 months to 23.7 months, and again, with a hazard ratio of about 0.61. Next slide, please. So there are 2 trials here, both using combination therapy, one osimertinib with chemotherapy, the other amivantamab with lazertinib. So far, both of these have got matured PFS data, but their OS data is still immature, and ongoing studies and data is awaited. So do you think that this advantage seen in the PFS in the first-line metastatic setting is really enticing to use either of these combinations based on their availability in your practice? And let's start in the reverse order. Dr. Darshana, what's your opinion about these combinations?
So definitely the data looks very much promising, and definitely I would like to use, though I haven't used as yet. But definitely in lung, even the PFS benefit I feel is good enough to implement, and this PFS benefit is significantly more, like by 4 or 5 months. So it is definitely something that I would like to use.
Yeah. So, one particular problem that we see in patients with driver mutation positive lung cancer, especially in the EGFR group, is that their acceptance of second and subsequent lines therapy is actually not so good. We've seen that even when we were giving the sequential way of first generation TKI followed by osimertinib versus chemotherapy, and that has always been a challenge. Dr. Kaushik, what do you feel about these combination therapies, and how can you place them in your practice? Do you use any of these combinations?
No, definitely, sir. The Mariposa we will not be able to comment, sir, because both the lazertinib or amivantamab have no much of experience of using the drug. But the FLORA-2, yes, osimertinib with chemo anyone having 2 years plus benefit of PFS, it's a welcome. And you have delineated in the talk that managing the osimertinib toxicity is much comfortable compared to the first and second generation TKI. Patients are tolerating it well. So I think it's too impressive data, Flora 2, and it can be a practice changing if availability is not possible. Affordability.
Thank you. Atul, what do you feel?
So data is good about amivantamab. Really, I feel that toxicity is going to be a concern. Hypersensitivity, thromboembolism, all these things. I feel it's going to be a little tricky drug to use. Osimertinib with chemo is data is really good. I think one can consider if patient can afford.
Pritam, any particular patient who you'd like to use a combination of osimertinib with chemotherapy? And any experience regarding the same?
Yes, sir. So I think in those patients who have increased disease burden, large disease burden, and those patients who have a CNS metastasis particularly, I would be more inclined to use the combination of chemotherapy with osimertinib. Amivantamab plus lazertinib, again, we don't have it. Amivantamab, we have the as Dr. Atul rightly mentioned, the toxicity is going to be tricky and challenging, and our acceptance for using amivantamab is still not that much as we have accepted osimertinib. The other concern would be the acceptance of the patient, because osimertinib is a tablet. Continuing this tablet for 2 years, 3 years is an easy job. Because the patient just has to take a tablet. But continuation of chemotherapy for that long time in an Indian setting is always going to be challenging because the cost involved, and obviously patient has to. All these patients are working to keep the patient off their work for 2 years, 3 years. It's so there are many problems in choosing.
Yeah. I think there is a practical logistic issue.
Yeah. Yes.
Okay. Can we go to the next slide, please? So I think what was very impressive is that in about 40% of these patients, there were brain metastases which were stable when the patients were enrolled. And if you see in both the studies, the Flora 2 as well as the Mariposa study, there has been a significant improvement in the CNS DFS. In the Flora 2 study, it's the HR is 0.47. And in the Mariposa study, the HR is about 0.69. So an important point to take forward is that uh, these studies have clearly shown that the addition of these dual therapies impacts CNS recurrence. And that is a major site of failure for most patients with EGFR positive lung cancer. The next slide, please. So in the Flora 2, you can see the response when compared to osimertinib monotherapy. And if you look at the column on the right side, which was about patients who had a confirmed CNS metastasis, the column on the left side is those with measurable as well as non-measurable. If you look at the right side of the column and look at the duration of response, it is 21 months versus 12 months in the osimertinib monotherapy. And the complete response rates are also 48% as compared to 16%. So I think this is probably one major advantage of the use of combination, and probably in a patient who has brain metastasis, it would be the treatment of choice. So has anybody in the group have any experience with the use of osimertinib along with chemotherapy? Anyone who's used them can please share your experience. Atul? Dr. Darshana?
No, sir, no experience of this combination.
Pritam, any experience of this?
Only one patient.
No experience, sir.
A few months, 3-4 months only just now.
Okay.
So I think.
Dr. Shruti? Okay, so I have experience of 3 patients who are on this combination. Out of 3, one had an extremely high, in fact, had recurrent effusions, and I started the chemotherapy combination 1 month after starting only osimertinib because the effusion wasn't just going. And the other 2 patients had CNS metastasis. So far, they all seem to be doing well, and the combination seems to be quite tolerable. Next slide, please. So I think it goes without saying that we image our patients at baseline. And I think that is a standard protocol for every patient with actionable mutation. My question to the panel is, how often do you monitor the CNS? Atul, how often do you do imaging, serial imaging for the CNS?
So, usually we do at the baseline. If patient has a brain metastasis, at least like if patient has no new symptoms, once in 6 months, at least I try to get a MR brain imaging if patient is not symptomatic. And in the initial time, once in 3 months, but once we have achieved some response, if there's no new symptom, at least once in 6 months, I try to get it done.
Dr. Kaushik, how's your experience and protocol?
So usually we do at baseline, yes, sir, for almost nearly 100% we do at baseline. But later on, it is just follow up, and only if someone is symptomatic or high clinical suspicion, then only we do with the MR.
Okay, Dr. Darshana?
I agree with Dr. Kaushik. We do at baseline, and then thereafter we do it only when the patient has any symptoms, or if the PET findings at subsequent evaluation shows some dicey things in the brain, then we go ahead with the MRI. Otherwise, we are not doing. The asymptomatic patients, so we never do subsequently until required.
Preetham, how do you manage a patient with a CNS metastasis, symptomatic, asymptomatic, either ways? Preetham, you're not audible.
So you will have to unmute yourself.
Yeah, sorry. So, so based on, either this patient is symptomatic or asymptomatic. Secondly, what we understand is if the patient is affordable for osimertinib, then I would not sort of give the radiation to the brain. And the patient is not affording for osimertinib, then and symptomatic, then I would go ahead with giving the radiation to the brain and put him on second line TKIs.
And your choice of radiation is based on the number of lesions?
Number of lesions,
SRS versus whole brain. Okay, next slide, please.
Sorry, sir. I just want to. Sorry, I just got that question a bit confused. So, patient who already has a brain mets, and then if we have to monitor, was that the question?
Yes. I meant that a patient
so
who
then,
has brain mets.
Then we have to keep monitoring it frequently. But definitely once a year, or maybe till or whenever the symptoms do occur. That is
okay. So if your patient is brain CNS negative at baseline, you will not monitor during therapy unless symptomatic.
Yes.
Whereas the patient has got a baseline disease, then you will monitor more frequently.
Yes,
okay, I think that's acceptable. So the FLORA 2 also showed that irrespective of the type of mutation, exon 19 versus L858, there was an improvement in the DFS in both the groups of mutations. Next slide, please. So coming to the side effects, Atul, how's been your experience managing the combination of osimertinib and chemotherapy?
Sir, as I mentioned, I don't have any experience, but I think compared to JEF plus chemo, it is going to be better because osimertinib, patients hardly do complain of any major side effects. Gefitinib also is a good drug to but I think with combination, I think osimertinib is going to do fairly better.
Any particular concerns with amivantamab and lazertinib combination?
So I read the paper. Hypersensitivity is almost always there, and the thromboembolic events, the nail changes, the thromboembolic events also are very common. So these are really concerning. And then first week through weekly, then every 2 weekly. I don't know how feasible is the combination.
So correct. While both the combinations seem to be efficacious, I think a lot of us will be more comfortable with the combination of osimertinib and chemotherapy because this is something that we've used multiple times either together or singly. And again, with amivantamab and lazertinib, this is a new drug I have not used in any patient. I think in the panel, nobody has used this combination. Amivantamab has just been recently available. Does anybody in the panel have you used amivantamab? Kaushik, sir?
No, sir.
No, Preetham? Any use with this drug? So I think reactions, infusional reactions are a major concern. And as Dr. Atul mentioned, the concern
Only
about
one.
thromboembolism. Sorry, go ahead.
So only patients are now at present ongoing, sir.
You have one patient who is taking amivantamab. Can you share your experience with the drug?
Yes, sir. So the reaction was the major problem, sir. Only 4 cycles completed weekly. But yeah,
So,
hypersensitivity reaction was the major challenge.
and you've used it in an exon 20
And
mutation insertion.
yes, yes.
Okay. Is Dr. Shruti still with us? I'm not able to see her on the screen. Kavina Creations, can you just confirm whether Dr. Shruti is there with us? Can we go to the next
Ma'am
slide,
is
please?
blocked out.
He's blocked out. Okay. Can we go to the next slide, please? So we just mentioned the side effect profile of both the treatment groups. And what is important to note is that these side effects are predominantly seen in the initial time. Possibly in the chemotherapy arm, it's because the chemotherapy, once you stop the chemotherapy and the later part when the patient is only on osimertinib with pemetrexed, the side effects really decrease. And over 9 months, there's a significant reduction in the side effects. Next slide, please. So I think we discussed these side effects. Let's go to the next slide. I think we discussed this point also regarding choice of patients for the FLAURA2 regimen. Next slide, please. So this is where we stand today. In the first line setting, we have 3 options. You could either consider osimertinib alone, or osimertinib with carboplatin and pemetrexed, or a combination of amivantamab and lazertinib. I think that's something that not many of us have got too much experience. Based on what is used in the first line, you have second line options, which could be chemotherapy or immunotherapy, something that's not mentioned here, that in patients who have progressed post osimertinib, you have the option of the ABCP regimen also. So a lot of this is dependent on what the patient has received in the first line, what he has tolerated, and the presence and absence of the CNS metastasis. Next slide, please. Again, this is of course a cross-trial comparison where it shows that apparently FLAURA2 with the kind of combination they're using and reserving amivantamab and lazertinib for a later date seems to have an improvement in the overall progression-free survival. But I think it's only, you're not going to get head-to-head comparison with these drugs. And as of now, the drug combination that is available for our use today is osimertinib along with chemotherapy. Next slide, please. So I think we have again discussed this. Dr. Suparna gave an excellent talk about the NGS report and decision points regarding starting treatment. Next slide. Next slide again. So I think we've come to the end about this part of the treatment, but I'd like, since we are talking about EGFR and ALK mutations, I thought of covering some of the important studies that have come right now, mainly from the point of adjuvant therapy. Can we go to the next slide, please? And the next one. Yes. So we recently had data from the Adwaita trial. A question to all the panelists, how many patients of yours come with resected or have potentially resectable lung cancer? Atul?
Sorry, potentially resectable, I would say around 10 to 15%. 10% max.
Okay, Dr. Kaushik?
Less than 5%, 5 to 10% max.
Dr. Darshana?
So 5% or less actually.
Okay, so the international studies put it as a quote of almost 35%, but I think in my practice it is probably 5 to 10%. Nevertheless, this is an important subgroup. So these are patients who had stage 1B, 2, and 3A EGFR mutant lung cancer, and these patients either received or did not receive chemotherapy, 4 cycles of adjuvant chemotherapy, and then were randomized to receive osimertinib for a period of 3 years versus placebo. And the primary endpoint in this was a DFS. Next slide, please. So this study, when it was initially reported in 2020, showed a significant improvement in the DFS with a hazard ratio of about 0.24, indicating almost a 75% risk of reduction of disease recurrence. And now we have the overall survival data also. and there is again a 0.48 hazard ratio, indicating a significant improvement in the overall survival with the use of adjuvant osimertinib. So my question to my panelists is, has anybody used adjuvant osimertinib in this setting? Dr. Atul?
No, sir. Never had experience.
Dr. Kaushik?
No, sir. No, sir.
Dr. Darshana?
So can you please repeat the question? Actually, I couldn't hear.
Adjuvant osimertinib. Have you used on the basis of the Adwaita trial? It has an overall survival benefit.
No, sir. No, sir. Not yet.
Not yet. And Dr. Preetham, are you there?
Yes, sir. No, sir. I have not used it, sir.
Okay. So I think so there are a lot of next slide, please. So there are a lot of caveats in this study. So one of the important thing was that CNS efficacy is very good, and even the CNS hazard ratio is 0.24, indicating a very good activity in preventing CNS metastasis. Next slide, please. But in my opinion, there have been a lot of concerns about the data of this study. One of the biggest limitations is that crossover is not allowed. Can we go to the next slide, please? In about 60% of the patients, the placebo arm did not receive osimertinib. And I think in today's time and era, when osimertinib is the accepted first-line treatment, this is absolutely unacceptable, and this is likely going to impact the osimertinib, the overall survival. And I asked you earlier about CNS monitoring, that this was one trial where patients did a baseline CNS evaluation and then only had metastasis. In spite of being on a clinical trial, they did not undergo serial CNS monitoring. And as a result of which, that has also shown an improved CNS activity of osimertinib. Had patients been monitored more frequently, this difference probably would not have been there. There have been a lot of earlier studies where it showed that 2 years of geftinib was not adequate. And we know that 3 years, as per this trial, has shown a survival benefit. So the current standard of adjuvant osimertinib is for 3 years. Next slide, please. Again, a little data we have about ALK positive in the adjuvant setting. I have absolutely no experience, and this is probably just 1 or 2% of patients. But again, we have data from the ALINA trial suggesting a significant improvement in the DFS with again a hazard ratio of 0.24 with an OS benefit, which an OS data that is still awaited. So I just wanted to cover the adjuvant space also, and therefore I included both these studies. I think next slide, please. So that brings us to the end of our presentation. If there are any queries or questions or comments, please go ahead with it. Okay, otherwise, I'll thank all the participants and I'll thank the organizers, AstraZeneca, as well as Kavina Creation for giving us this platform for discussion. Thank you all so much, and have a good day.
Thank you, sir.
Thank you, sir. Thank you all.